So hi, everybody. I think we're going to start the breakout session here. And so this is the session for relapsed refractory myeloma. Dr. Razzo is doing the one for newly diagnosed. And I think the topic was to talk about risk and how to decide about CAR T-cell therapies, toxicities. But really, we can open it up to anything. This really is meant to be interactive. So any questions you have about CARs or treatments in general, how to decide about a treatment, please just raise your hand and we'll talk about it. I did want to start with this video, though, just because I love this. It's 3.5 minutes. It just talks a little bit about the initial experience of CAR Ts in that first pediatric patient that was treated at Penn. And I think this is from around 2012. So maybe we can just go ahead and play this to get started.
Is it hard for you to say those words, "We're trying to cure cancer"?
That's a really good question and why it's hard to say.
So thanks, guys. Just always like to see that and give hope. And there's actually a longer, I think, full feature-length film now based on that experience that's available. So I really wanted to just open this up for questions at this point and just hear from you guys in terms of what you think about this, what kind of questions come up. Actually, maybe before I do that, can I just see in a show of hands, has anybody had CAR T-cells here? Wow, 1, 2, 3, 4. That's great. And has anyone had a bispecific antibody? Okay, we're going to hear more about that later. These are really remarkable new treatments that activate the immune system that I think are revolutionizing how we manage myeloma. So why don't we open it up? Does anybody have a question they feel brave and want to start with? Do we have folks with microphones in the audience? Okay, go ahead.
When you talked about the bank of cells that some people would use for the CAR T, is there any risk of rejection like there is from a transplant for, say, a kidney or something like that?
Yeah, not really. Because the cells are made from your own cells, they're not rejected. And so that is not something we've really seen. Some of the newer products that are being tested that are off the shelf, where they make it from healthy donors, that is one of the risks. And those, unfortunately, those CARs don't stick around quite as long. And so one of the issues that scientists are trying to come up with is how can we make them last longer. But no, when they're made from you, they're not rejected, fortunately. Other questions?
Hello, Dr. Cohen.
Oh,
right here.
Oh, yeah, hi.
Hi, I'm Jason. I'm one of the second-year internal medicine residents. My question is, when you said if a patient gets CAR T-cell infusion and if they ends up getting a CRS and if they get tocilizumab, does that affect efficacy of the CAR T-cell? Is there any drop in efficacy or progression-free survival or anything like that?
Yeah, that's a great question. So really what we're asking is if you get this antidote drug called tocilizumab to help treat that cytokine release syndrome, does it affect the CARs? And the amazing thing is that it does not. And that's really what's been so remarkable. It sort of tamps down the immune system and keeps it from getting overactivated, but it doesn't kill off the CAR T cells or affect them. And so it has not been shown in any of the studies in any of the diseases, including myeloma, that it impacts it. So we're much more willing to now give it. I think in the beginning we didn't know, and so we were waiting until patients were getting sicker before we'd use it, but now we use it much earlier. And there's even studies of prophylactic tocilizumab where it's given in advance, mostly for bispecifics, less than for CARs, to try to prevent that reaction from happening at all. That's a good question.
CAR T, what is the age group to do it?
So there's no upper age limit, and we've definitely treated patients into their mid-80s. And one of my colleagues at MD Anderson, as she said, she's treated a 90-year-old. So it's really a matter of physiologic age. Particularly, do you have, we think, good heart and lung function, the reserve to handle this cytokine release syndrome? You know, patients can get tachycardic, they can have fast heart rates, sometimes low blood pressure, and so you want to make sure you don't have severe heart disease or severe lung disease. But there's no really upper age limit. I think it's actually easier to get CAR T than a stem cell transplant. And so you have patients who may be transplant ineligible, but who are still eligible for CAR T.
In relationship to the CAR T therapy, if you have gene mutations, is it affected differently?
You mean if you have like the chromosome abnormalities for your myeloma?
Yeah, like a deletion.
Yeah, so no, it doesn't affect the initial response. So patients of all different types of myeloma have responded well to these. But there are certain high-risk genomic abnormalities like deletion 17p or 1416. Those patients, unfortunately, tend to have shorter remissions with all myeloma therapies. And it seems like with CAR T, they may also have slightly shorter remissions. So we're still getting them into remission, but they may not last as long. So that's where there's a lot of interest. These are called high-risk cytogenetics. In maybe, is there something we can do after the CARs to sort of, in those high-risk patients for relapse, to see if we can extend the remission duration? So there's some trials going on for that now. Oh, over here.
Yes, sir. So when I was diagnosed, I had kidney damage. I guess I still have kidney damage, but I don't have myeloma in there anymore. But kidney problems were shown on there. What would be the considerations for someone who already has kidney damage in CAR T?
Yeah, that's a great question. So it depends on how severe. There's something called the creatinine clearance, which is a sort of a marker of your kidney's function. And patients whose clearance was less than 30 were often excluded from some of the trials. So we didn't have as much data about those patients. It turns out, though, that you can treat patients with kidney damage, including patients in kidney failure on dialysis with CAR T. We've done it outside of trials. You have to modify some of the chemotherapy that you give in the beginning. Remember, there's 3 days of low-dose chemo that patients get before the CARs go in. One of those chemo drugs, fludarabine, is cleared by the kidney. So we have to lower the dose or sometimes leave it out. But you can still do it, get the CARs to go in, and get them to expand, even in that population of patients. We have to watch them closely. I usually admit those patients to the hospital the whole time. And we've done it with dialysis patients. We have to monitor their fluid status, but it can happen. So just having kidney damage shouldn't preclude you from thinking about CAR T. You were asking about toxicities. So sometimes the creatinine levels go up. You can develop what's called acute kidney injury when you have cytokine release syndrome, sometimes in the setting of low blood pressure. And if you already have pre-existing damage, that may take a little longer to recover. So that would be the main risk, and that's something you would discuss with your doctor. But again, if we know that in advance going in, we can be proactive. We use extra hydration. We avoid any drugs that could affect the kidney. So we are generally able to get people through it, even with some pre-existing kidney issues.
So I have a couple questions. I had a stem cell, had a bad reaction towards the end. Considering the CAR T now, is that something that I need to be more concerned about? Like I can't think of it. I can't remember the name of it, but I was rejecting my own cells.
You're rejecting your own cells,
Yeah.
like your blood counts were low or something?
Oh, I
like
had
that?
really high fevers. I went into AFib. I just
Got it. Yeah, so it really is a different type of cell that we're infusing in.
Okay.
So the stem cells are collected and really infused in to help repopulate the bone marrow after you get high-dose chemo to wipe it out. This is really a different situation. The low-dose chemo we give you doesn't wipe out your entire bone marrow, so you don't need stem cells with CAR T, and the T cells, I wouldn't expect the same type of reaction. So I don't think having a reaction to one should preclude you from considering the other.
Okay, the second question is I'm predisposed to Parkinson's.
Mm-hmm.
So is that something that maybe I may get that Parkinson's reaction as a side effect because I'm genetically?
That's a great question. So we don't really understand all the risk factors for the Parkinson's. Fortunately, it's pretty rare, but I would say I did have one patient of mine who was recently diagnosed with Parkinson's, was developing it as we were discussing CAR T, and I opted not to give him Cilta-cel, the CAR T product that has a higher risk of Parkinson's. I gave him Ida-cel, the other one. So that might be something I would consider in your case. Again, I don't think it precludes you from getting it, but maybe use a product with a lower risk of it, just to take that off the table, hopefully.
Okay, is CAR T a one and done?
As of now, yes. It's a one-time treatment, and then you're done. There were some initial studies trying to give the same CAR product again to patients if the disease came back, and those did not show great efficacy. It seems like even though they're made from your own cells, once they've gone into you and you try to give them a second time, they don't tend to stick around or last very long. So what you can do is switch to a different CAR T product, and that has been done successfully in small numbers. But right now, most insurances are only covering one. So it's probably a one and done, at least commercially, but you could get on to a trial and get a different one later, and that might work. Here's one in the back.
Yeah, and thanks for this very, very educated. I'm from Seattle and try to follow the best CAR T cell seminar. So thanks for having this. I have a question about sequencing. Because if CAR T move to more frontline, so how that will affect the sequencing. For example, if a patient have VLK, traditional VLK Revlimid, when refract, he doesn't go through the so-called DARA PAM, instead go to CAR T cell. So will that impact after, come back to DARA and PAM, or need to go, you will recommend probably more about immunotherapy line rather than DARA, PAM, or this different line,
Right. Yes, that's a great question. So it's really asking about, with all these new therapies, what order do we go and how do we sequence them? And this is something that we as a field, I think, are still struggling with and trying to understand. So we have some of these studies suggesting that, say, in 1 to 3 prior treatments, that early relapse period, that CAR T may be better than the standard regimens, like you mentioned, DARA, pomalidomide, dexamethasone. And so I might, yes, choose CAR earlier, but you can still use those regimens later. So they still will work. Patients will respond to some of the older drugs if they've gotten CAR T or bispecifics earlier. They may still respond later. So I think until we get more patients cured, still we're going to be needing all of these drugs and using them. And the question is, what's the best order? And I think that's what we're trying to learn now. But I don't think moving the CARs up is going to say, no, now those other ones are no longer useful or off the table. They'll just be pushed a little bit later.
Okay, thank you.
Yeah. There's one right here. You need a question up front?
Talking about sequencing, so how about lines of therapy? So I know there's a little bit of, kind of wiggle room with that. So could you sort of explain that a little teeny bit?
Sure. So this is something that we struggle with a lot too sometimes. So a lot of the trials are written based on how many lines of therapy you've had, maybe how many different regimens you've had for myeloma. And this can sometimes be counted differently by different doctors or different centers. And so to me, a line of therapy is a sequence of planned interventions that you do all together without any progression in between. So if you got VRD, Velcade, Revlimid, Dex, and then a stem cell transplant, and then Revlimid or lenalidomide maintenance, even though that sounds like 3 treatments, that's one line of therapy, because your myeloma was controlled and that was planned the whole way through. But if you got VRD, Velcade, Revlimid, Dex, and your myeloma didn't really respond very well and then started to grow back, and you got switched to daratumumab, pomalidomide, Dex, and then went to a transplant, that's 2 lines because there was a change you had to make. And so this is how myeloma drugs have been approved, unfortunately, based on lines, and you have to do these calculations. We're trying to get away from that and trying to convince the FDA, actually, that that's not as important as what drugs have you had and is your disease resistant to those drugs? Because now that we're using quadruplets, as we heard up front from Dr. Carr, you're getting exposed to all these drugs right from the start. And you might go through all of the standard myeloma drugs in 1 line or 2 lines. And then if a drug's not approved until if you've had 3 or 4, then you're scratching your head saying, I want to get this drug, but you say I haven't had enough lines yet. And this makes it hard because sometimes insurance companies are sticking very strictly to this and are denying things. So this is a problem, I think, not just in myeloma, but in oncology therapy in general. And we're trying to change the paradigm to think more like, what drugs has the patient had? Are those drugs used up and now they're resistant? and let us use the next drug earlier. So it's a struggle. Sometimes we have to fight a little bit with insurance, but we'll get there.
Following up with that, do you consider tolerance of those drugs as like moving on to the next line of treatment? So say Revlimid, so say you've had to step down in the dosage of Revlimid multiple times. Do you consider that being able to move on to CAR T if you feel like you're not able to tolerate that as well?
Right. Yeah, so I do. I'd love to. My goal is to get patients to say as many lines as possible so that I can get them the drugs they need. So it's convincing sometimes an insurance company for that or a trial to get in. But yes, we're trying to write trials now to say, progression or intolerance. And so if you started on Velcade Revlimid and you had terrible neuropathy on your Velcade and had to switch to Kyprolis, carfilzomib, Revlimid, even though your myeloma didn't progress, I consider that switching lines. Like you changed drug for an unplanned reason, not, wasn't what your doctor originally wanted. So yes, I would count that.
Yeah. Hello, Dr. Cohen. Good to see you. Thank you for joining us again. I enjoyed the presentation very much. For a patient in remission, clinical remission, but MRD positive, and also consider how wonderful the CAR T outcome is. Should a preemptive CAR T be considered for the next step?
You mean for a newly diagnosed?
No, for the, newly diagnosed, but MRD positive.
Got it. So great question. And maybe just so to everyone make sure we understand, MRD is minimal residual disease, and right now it's a bone marrow only test. Hopefully we'll eventually get it in the blood, but it's a way to look, a very sensitive way to look for as little as one myeloma cell hiding amongst 100,000 or even 1 million normal cells. And with these technologies, you can really identify patients who are MRD negative by that testing, which seem to predict for longer time in remission, versus MRD positive, meaning there's still a little bit of tiny bits of myeloma left. And in that setting, it predicts for somewhat shorter remissions, even though the patients may otherwise be doing really well. And so we know it has predictive value. The question is, should we be acting on that and making changes in the regimen or intensifying treatment in someone who otherwise is doing well but has that MRD positive? And that's, I think, what you're getting at, and that's a big question for the field right now. And so I will say there are trials certainly doing that, where patients who are MRD positive are randomized to a more intensive intervention or standard to see if that leads to better outcomes. We're just starting to get some data to suggest that might make a difference, but we don't have that data yet for CAR T. And so I am not, at least right now, using that to make my decision about whether to move to CAR T or not. If somebody is in a really deep remission after their initial induction therapy, their 4 drugs, quad or transplant, whatever it is, and they still are MRD positive, I would not personally take that patient right to CAR now. I don't think we have the data to support it. I think there are trials that are looking at that. And I think we need to sort of wait for that, because it is a big commitment to commit somebody to CAR T. And that patient, may also still do very well for years, even with MRD positive, and then still have CAR T available. And maybe the CAR Ts in 3 years are going to be less toxic and more effective than the ones I have now. So again, I would wait a little bit for more data. But that concept or paradigm of making a change in treatment based on MRD, that is coming. I think a lot of those trials are being done. Some of them are starting to read out. And so in the future, we're probably going to be doing more risk and response adapted treatment. We're going to look at your risk profile. Do you have these high risk cytogenetics? We're going to see how well you did with your initial treatment, and then we're going to go down different paths that are more individualized for each patient. I do think that's the future. Maybe not yet.
You said that a second CAR T you might be able to get on a clinical trial. Would a second one work?
So we don't have a lot of data yet, but there's some. There have been some small studies published in China. We have some small experience. If you switch the CAR, so it's a different one than the one you got before, that may work And I have some patients who actually got CARs on our original Penn trial in 2015. The disease came back, and then I gave them a different CAR, and I got them back in remission. But the key is you have to switch. And where I think will work even better is not just switching the CAR, but switching the target. So most of the CARs now, we talked about, hit this one called BCMA, and that's where the approved ones are. But there are new CARs coming out that hit different targets, including one called GPRC5D. And there's a trial, there's been several studies now showing that if you switch different target, you can get them back, patients back in remission with a second CAR. And there's a GPRC5D CAR that's being developed by BMS that's in later line development. You know, that's looking specifically in that population, people who've had a prior CAR, and they're seeing nice responses. So stay tuned. I think this is not standard of care yet, but it's getting there. We're getting more data to suggest this is going to be possible.
Thank you. If you've had a CAR-T procedure and your immune system is suppressed, you need IVIG infusions, and some side effects like a cytomegalovirus that is still residual. Do you find in time that sometimes it can improve, or does it go away?
So thank you. That's actually a great point to bring up, that even though once you get your CARs and you're off myeloma treatment, there are a lot of supportive care things that you need to do, especially early on in those first several months, to sort of protect you from some of the side effects and risks. And one of the ones you're bringing up is something called hypogammaglobulinemia, meaning low immune globulins. So the CARs target not just the myeloma cells, but your normal plasma cells that make our good antibodies. And so that puts you at risk of infection. And so all the patients who get CAR-T get these infusions once a month in the beginning called IVIG, intravenous immune globulins, which are basically getting good antibodies that help boost up your immune system and help you fight off infections. And so we do this monthly for patients. I'm giving it at least 6 months in everybody, and then I tend to go based on your IgG levels. And some patients do start to recover their normal immune globulins by that time, and once that IgG is above 400 and staying on its own, I'll start to space out the IVIG every 2, every 3 months, and eventually get them off. But I have some people that are still 12 months, 18 months needing it, so every patient is different. I'd say it's, you know, typically between 6 and 12 months they're needing it, and then, but the nice thing about CARs are you do eventually get off of all that stuff. Your immune system does recover. And CMV, cytomegalovirus, is a virus that we all have exposure to. Many of us have it in our system dormant. It can reactivate sometimes after CAR-T or any process that suppresses your immune system. Fortunately, though, actual CMV causing disease is pretty rare. It sometimes will show up in the blood and lead to some low blood counts. And if that happens, it is treatable with antiviral medications. But it's not usually a major toxicity or issue long term. We do, though, give everybody some preventive medicines to help prevent infections. Everyone is on acyclovir or valcyclovir, these antiviral drugs. Most people are on a medicine to prevent a certain type of pneumonia called pneumocystis, either Bactrim or Dapsone or atovaquone. And some patients do need other antimicrobials, especially in the first couple weeks. So there is a lot of supportive care that goes on with this to try to really help prevent these infections, and that's most important in the first few months, but can sometimes linger on longer, as you mentioned. Yeah.
Thank you for your presentation. It's wonderful. Do you have any experience with patients who have had teclistamab or a bispecific? Is that ever followed by a CAR-T if they fail the bispecific?
Yeah, so that's a great question, and it gets to that whole sequencing question before. So the answer is yes. A lot of us have patients who go through all of these different immune therapies, and the best order to do them in is sometimes a challenge. What we have learned from earlier data is that if you've had a prior bispecific antibody like teclistamab or talquetamab or elranatamab, these drugs that also act by waking up your T cells, if you're try to collect T cells for the CARs right as you're coming off of those bispecifics, as the disease is growing, it can be challenging sometimes to get a good CAR product. The idea is that these bispecifics are sort of activating your T cells every week or every couple weeks, and the T cells may get exhausted or overused, if you will. And then when you try to collect them and make a CAR product, the CAR product may not be as potent or powerful. And that's what we saw in some early trials where we were doing CARs after bispecifics. So that's led to this idea and this sort of recommendation amongst most of the CAR centers that if you have a choice between the two and all things are equal, we've usually preferred to do the CARs first, because you get the CARs and the benefit. Patients are usually off treatment for a long period of time, sometimes even a few years, and then the T cells are healthier, and then when you try a bispecific, it may work better. So I've usually done it the other way around. What we're learning, though, is that these bispecifics, which initially in early studies were given indefinitely, we might not have to give them for so long. And so maybe if we just give the bispecifics but stop them after a period of time, and that's what Dr. Garfeld is going to talk about this afternoon. We have this trial of limited duration bispecifics. You can get the benefit of it, but you don't keep hammering the T cells every week or every month, forever, for years. You give people a break, and then maybe if you try to collect CAR Ts later, we'll have a better success. So right now we'd like CARs before bispecifics, but in the future maybe that won't be the case, and we'll be able to go back and forth as long as we give people a break. Great question.
Hi, do you treat patients differently based on their genomic mutations like T414, deletion 13, T53 mutations?
Right. So at least right now, for a newly diagnosed patient with that, my initial therapy doesn't change. I'm still using quadruplet 4-drug treatments. We use mostly Dara-VRD with Velcade as the proteasome inhibitor. Some centers are using Dara or isatuximab with KRD, meaning Kyprolis or carfilzomib. So that is one difference that some places make based on risk. Where I do make a difference, though, is like Dr. Carr mentioned, I do push transplant a little more in those higher risk patients because they tend to have shorter remissions with standard treatments. I tend to use more double maintenance, where I'll pick 2 drugs as the maintenance as opposed to just lenalidomide or Revlimid alone. And then I am more inclined, if their disease comes back, especially if it comes back early after a transplant, to push maybe for CAR T cells right in that second line, just because they've shown me they have a little bit higher risk. So it may not affect my first choice, but it does affect what I do, as maintenance and down the road. Also, we are now starting to get drugs tailored towards some of those genetic abnormalities, and so it might impact the ability to get into a clinical trial later. For instance, we have a study at Penn specifically for patients with a 414 translocation that uses a small molecule pill that's supposed to target that particular translocation. So we need more of those type of drugs. They're really targeted therapies, and for certain mutations. They have more of those in lung cancer and other diseases, and I think we're working on it in myeloma. We're not quite there yet.
Okay, we have time for maybe one more question, and then we'll go to lunch.
In the back here.
So one of the things I'm curious about is in a lot of the slides, when I was first diagnosed a long time ago, it was 3 to 5 years. And a lot of the data is also kind of in that 3 to 5 year period. Are you guys, or is anybody looking at, I'm gonna knock on wood right now, it's been 15 years since my transplant with like nothing. Wow.
Good.
Thank you. I do celebrate that. Thank you. But I'm wondering, like, is there a point in time where this gets, all these treatments get so advanced and people are doing so well that it almost sort of starts the clock over again? Like, am I going to have to go back through all of the 3 and 4 different iterations before we then come to like CAR T? Or is it, you get to that point and you're like, you're completely different than everybody else, which I think everybody is, just depending on what the genes and stuff are. But
Right.
is there anything that's a longer term study now, because it has been so successful over the last few years, of people really extending life expectancy?
Yeah, so it's a great question. We don't have 15-year follow-up data yet for CAR T. I think the longest, for the CAR trials all started in myeloma with BCMA in 2015. So we're getting there, and there still are a handful of patients that are, maybe in that 7, 8, 9 year remissions. We do have that with stem cell transplant, though, and like you, there are a subset of patients who are out 15, 20 years or beyond with just a single stem cell transplant. And so there have been a few groups that are trying to publish on those patients and trying to understand what is it about is it their disease, is it their immune system? And the answer is it's probably a little of both. They have myeloma cells that may resemble more what's called MGUS-like state, this sort of precursor to myeloma where the cells may be a little less aggressive in some cases, and also their immune system in some cases has reset to the ability maybe that they're providing some sort of control of their disease. So we're trying to learn more. I agree with you, there haven't been enough studies on those sort of super long-term non-progressors, as I would say. But I think that there's interest in that, and certainly in all the CAR trials now, there's an interest in seeing, who are the patients that have had 5 years or more remission with no other treatment, and what can we learn from those patients? So there's an effort for that. Your other question, though, about do you need to restart and go through all the quads and all that again, I think that's evolving. Right now, the answer is probably yes, you would at least, if you've relapsed, go back on some combination regimen. But in the future, it might be just going on a bispecific or going on a CAR T, if they get approved in that earlier line setting and we learn that they can work that well by themselves. So we're trying, we're hoping to get to less toxic, less steroid requirements to make it better.